Greetings everyone. Today I'll be explaining about the substance use disorder, and especially I'll be talking about the depressants. There are other substance use disorder, and that will be dealt in the subsequent videos, and like the hallucinogens as well as the let's say stimulants. Okay, but in this we'll talk about what is substance use disorder and what are different types of depressant. I will be talking about benzodiazepines, barbiturates, opioids, inhalants, and alcohol, of course. And yes, this video will be very much helpful to all those students who are preparing for USMLE examinations, and as well as PLAB and NCLEX examinations. So yes, I'll try to cover much of the topics that is really important in examinations, and I hope after listening to this video and then going back to your books, it makes it much more efficient for you and much more quicker for you to grasp the thing. And one more thing, if you think the speed of this video is slow, then you can always increase the speed and watch it in YouTube. Okay, now let's move forward. So substance use disorder. So what is substance use disorder? It means a person is taking some substances, and that in a maladaptive pattern characterized by clinically significant impairment or distress. So in this phase, a person will be taking some substances which has a maladaptive pattern of use. I mean, they are not taking that which is within the normal limit, and yes, because of that they will have some significant impairment or distress. And there are 11 different criteria that has been set, and the person must match at least 2 out of 11 criteria to say that he or she has substance use disorder of that particular substance in the last 12 months. Okay, so it is definitely a chronic process, and there is always a relapsing disorder. That means if a person tries to quit it, then there is always a chance that he may be back to that habit of taking the substances. So out of this 11 criteria, if the person meets 2 to 3 criteria, then we say it's mild substance use disorder. If it meets 4 or 5 criteria, then we say it's moderate substance use disorder, and if it meets 6 or more, then we say it's severe substance use disorders. So these criteria are: number 1, tolerance. The person, let's talk in terms of alcohol. Okay, so the person starts developing tolerance for the alcohol. So this means now he requires increased amount of the substance, that is alcohol, to achieve the similar intoxication level or the desired effect. And yes, sometimes we can also say that if he is taking the regular amount of alcohol, then in that case he won't be getting as much as the desired effect that he used to get. So yes, there is always one problem with the tolerance. Next is withdrawal. So if a person quits taking the substances, and if he starts developing the withdrawal symptoms specific to that substance, then we count this as one of the 11 criteria that is necessary to be called the person to be called as having the substance use disorder. Similarly, having intense craving for the substances, excessive use of the substances, and persistent desire to quit, but despite of that could not quit. So this is another criteria. Next is time consuming behavior. Let's say if the person is spending a lot of amount of his productive time in regards to the substances, like going extra mile to get the drugs, or let's say yes, or just in the just getting high and killing his time, then so we call that as one of the criteria out of 11. Okay, and similarly the functional decline, there are 3 points in functional decline. So like if the person is not performing well in his work, school, or home, that's one. Similarly, if he is abandoning the social, occupational, as well as recreational activities, that's another. And similarly, if the person is continuously using despite persistent social or interpersonal problems caused by the substances. Example, again, if the person is continuously taking this despite the social as well as family chaos after taking the alcohol, then we will also categorize this as 1 out of 11 criteria for substance use disorder, diagnosis of substance use disorder. Similarly, risky use of patterns, like if after taking the substance the person cannot control and he does driving, he does involve in unsafe sexual practices or operates heavy machineries, and that can be taken as another criteria. Similarly, if the person has started developing physical or psychological problem due to the substances, like let's say they started developing ascites or hepatitis, or like carcinoma, hepatic carcinoma, yes, or the heart problem after taking alcohol, but even despite of that he is continuously taking these substances, then we take it as another criteria for diagnosing substance use disorder. We must always remember one thing, like when we take substance use disorder, if the substances, example opioids, is being prescribed by the doctor, and if the person is taking that amount of the drugs as prescribed by the doctor, that we don't call that as a substance use disorder. Okay, now we'd like to go to the next topic, that is depressants. So as I said earlier, in depressants we'll be talking about benzodiazepines, barbiturates, opioids, inhalants, and alcohol. So in the brain, they enhance the GABA action. GABA is inhibitory neurotransmitter, so since the GABA is increased, so there will be depressed effect in the brain, and also they block the excitatory glutamate signaling in the brain. So because of that, again, there will be the depressant effect in the brain. So now let's move ahead with the alcohol mechanism and intoxication. Okay, alcohol, it works by modulating GABA A receptor. Okay, so it's a positive allosteric modulator for GABA A receptor, and now since the GABA is modulated, so there will be inhibitory neurotransmission in the brain, and yes, because of this, all those sedating effect occurs. Okay, and also anxiolytic effect occurs. So that's because of this, the person who takes alcohol feel less stressed, or let's say, and also sometimes gets sedated. And also we have to remember that alcohol, it also have NMDA receptor antagonism. So because of this, it inhibits glutamate mediated excitation. So glutamate actions is basically mediated through NMDA receptor. So now since alcohol is NMDA receptor antagonist, so because of that, the glutamate action cannot take place, and so there will be since glutamate is excitatory in nature, and since now it's not working properly, so yes, because of that, again, we can say that it leads somewhat to a depressant effect, or let's say cognitive impairment and memory blockouts. Now the clinical features of alcohol taking, alcohol intoxication, we all know that it causes emotional lability, behavior disinhibition, slurred speech, ataxia, impaired judgment and coordination, and if taken in excess, it can lead to CNS depression, sometimes leading to coma, and also anterograde amnesia, also called as blackouts. This value is important. The AST value in case of chronic alcoholic is 2 times that of ALT value. Okay, so this was an important question hint. Since sometimes in the questions this hint will be given, the AST will be 2 times as that of ALT, and there will be liver cirrhosis or something, and based on this value, we choose one of the options as alcohol mediated liver failure or liver diseases based on this value. But this is simply suggestive and not diagnostic. We have to remember this thing also. Okay, and the management is provide IV fluids in case of alcohol intoxication, IV fluids, thiamine supplementation if its airway is compromised, and airway protection, antiemetics, and so on. Now another important concept is alcohol withdrawal syndrome. So if a person who is chronic alcoholic if he starts quitting the alcohol, and within different let's say in next 48 to 96 hours, there will be various changes in his body. Okay, so in first 6 to 12 hours of quitting alcohol, he may develop anxiety, tremor, headache, insomnia, diaphoresis, palpitation, GI upset, and such features. And similarly, in next 12 to 24 hours, he develops hallucinations, and he may develop hallucinations. And hallucinations, visual hallucination is much more common than auditory or tactile. Okay, this is another question that is frequently seen in examinations. So, and similarly, so despite the patient is having hallucinations, he remains typically oriented to time, place, and person, let's say. And similarly, in the next 24 to 48 hours, there is the risk of developing seizures, and that's tonic-clonic, generalized tonic-clonic seizures. And in next 40 to 96 hours, the person may develop delirium tremens, and this delirium tremens, in this phase, their person will be in confusion, disoriented, autonomic instability, fever, agitation, and it can be life-threatening. Okay, so the pathophysiology for alcohol withdrawal syndrome is that in chronic alcoholics, there will be upregulation of excitatory glutamate receptors, and now this is somewhat balanced by the GABA A mediated action of alcohol. Now, since the person has stopped taking alcohol, so there won't be GABA A receptor mediated action. So hence, in the body, only the effect of upregulated excitatory glutamate receptors is seen, and this also means there will be increased activity in the brain, and because of this, all anxiety, hallucinations, seizures, delirium tremens, this occurs. So we all know that treatment is long-acting benzodiazepines, especially chlordiazepam and diazepam. Okay, and this helps to prevent seizures and as well as delirium tremens. Similarly, IV fluid, electrolyte repletion, and thiamine is necessary. Now, in next question, the topic we'll be talking about the barbiturates. So, barbiturates is another substance which is which has the potential of being abused. So in this page, in barbiturates, we'll be talking about the mechanism, and the mechanism is similar to that of alcohol. It is also a positive allosteric modulator for GABA A receptor, and because of that, there will be inhibitory neurotransmission in the CNS. And as a result, when the person is intoxicated with barbiturates, he develops sedation, respiratory depression, and potential to become in coma. And when there is the overdose of barbiturates, then there is high chances of fatal respiratory depression, and in that case, we have to manage the patient by providing respiratory support, blood pressure maintenance, and obviously intense monitoring is required. And if the person having chronic use of the barbiturates suddenly quits, and then he will develop withdrawal, and the withdrawal syndrome in case of barbiturates is similar to that of alcohol withdrawal, in which the patient develops anxiety, tremor, seizure, insomnia, and delirium, and sometimes the person may even die because of cardiovascular collapse. So the treatment is with, again, longer acting benzodiazepines, and we can gradually taper the benzodiazepines. Now, the third group of depressant is benzodiazepines itself. So the mechanism of action of benzodiazepines is okay. Now the next drug, as I said earlier, is benzodiazepines. So its mechanism is also again similar to that of alcohol and barbiturates, in which it acts as a positive allosteric modulator for GABA A receptor, and hence it causes depressant effect in the brain, and it has greater receptor selectivity and improved safety profile as compared to barbiturates. Okay, intoxication features is when if someone is taking benzodiazepines in excess amount, then he may develop ataxia, impaired coordination, respiratory depression, although it's minor most of the time, sedation, drowsiness, enterogate amnesia, Okay, and yes, this is another important thing. Flumazenil, it's a drug of choice. It's a benzodiazepine receptor antagonist that reverses the effect of benzodiazepines intoxication. And we have to remember one thing. This flumazenil is used in case of acute intoxication of benzodiazepines, but if it's used in chronic users, then there is always an increased risk of seizures. So what happens if the person taking benzodiazepines suddenly stop taking benzodiazepines? So in that case, there will be withdrawal syndrome, most likely, and the syndromes include seizures, anxiety, insomnia, sleep disturbances, depression. So everything the benzodiazepines used to have its effect upon, so that will be removed. And as a result, so since we know that benzodiazepines is given for seizure, now since you have stopped benzodiazepines in chronic users, so in this case there will be increased risks of seizures, there will be increased risks of anxiety, increased risks of insomnia, depression. Okay, now similarly we'll talk to our next drug, that's opioid. And opioid mechanism and effects, it's a we all know that opioid works by binding to mu, that is opioid receptor. And yes, most of the symptoms are based upon the effect of the mu, that's opioid receptors. Okay, now when we take the opioid drugs, and yes, these mu receptors are present throughout our central nervous system as well as peripheral nervous system. So when even if you as a doctor you prescribe opiates to the patient, then there will be therapeutic effect as well as adverse effect, because its mu receptor is present in both the central and peripheral nervous system. And yes, there will be adverse effect as well as therapeutic effect. But if it's taken on the street or as an street drugs, then in that case obviously there will be more adverse effect. Okay, so the symptoms of opioid intoxications will be, we all know that if it's too much, then it causes the reduced sensitivity to carbon dioxide as well. Because of this, there will be higher risks of respiratory depression and death. Similarly, it can cause meiosis in eyes, and we call pinpoint pupils. Okay, this is another important hint for opioid intoxication. So pinpoint pupils because of parasympathetic activation. And similarly, there will be CNS depression leading to sedation, euphoria, decreased gag reflex, and potential seizures, and also chances of constipation. So opiates are the most common cause of drug overdose death in the United States. Okay, so it's really taken seriously here in the United States. Even as a doctor or a nurse, you have to prescribe or administer opiates to the patient, you need exclusive charting for the drugs. Okay, and now opioid overdose and withdrawal symptoms. So we all know that the overdose can be life-threatening emergency because of CNS depression, respiratory depression. And yes, in examinations, if the person has CNS and respiratory depression as well as pinpoint pupils, then we think that's because of opioid overdose. Okay, and additional signs can be bradycardia, hypotension, hypothermia, decreased bowel sound, and the immediate treatment is naloxone. It's opioid receptor antagonist. It reverses the life-threatening effects of opioid drugs. And yes, but we may require repeated dosing of naloxone. So again, in examinations, if the person is, you get the hint, a person was in the hospital, taken to the hospital, he was taking some drugs, he had CNS depression, respiratory depression, meiosis, and was given naloxone. But despite of that, he came into normalcy just for a few minutes, and then again he had developed CNS depression, and let's say he became unresponsive. So then the question asks, why is it, what is the culprit? Then we still say it as opioid overdose. Okay, we don't think that naloxone is not working, so it may not be opioid. We still say it as opioid because we have to remember that for naloxone we may require repeated dosing, and single dose may not be efficient. But yes, overall, if you give the repeated dosing of naloxone, then this is the best treatment for opioid overdose. With overdose, the withdrawal syndrome, it includes several. Yes, so opioid withdrawal is often uncomfortable to the patients, but is not life-threatening, and onset occurs 6 to 12 hours after last use. It's based upon the half-life of the opioid drug which he or she has been taking, and yes, the symptoms can be now the opposite of meiosis, that's mydriasis, dilated pupils, piloerection, rhinorrhea. There will be a runny nose, lacrimation, running ears, teardrops coming from eyes, and yawning, and diarrhea, nausea, abdominal cramps, sweating. So basically there will be increased secretion type of thing in the body. Myalgia, pain in the muscles, insomnia, can sleep, and flu-like symptoms. Okay, so management will be methadone or buprenorphine for medication assisted treatment. If the person requires medication, then we go with buprenorphine or yes, methadone. Now the last depression we'll be talking about is inhalants. So we know that this inhalants is especially taken by adolescents, and it's readily available in the market because it's found in solvents, aerosols, gases, nitrites, and the most common one is the dendrite that is used in gluing of the shoes. It has this inhalants, and yes, because of that, the youth or the adolescent population who don't have much more money, especially in the living in the slum, they consume this. Okay, they inhale this substance. So mechanism is non-specific, so there will be non-specific disruption of cellular membranes and multiple neurotransmitter systems, and also there will be GABA signaling will be enhanced. So because of that, we have categorized this under the depressants. Okay, intoxication, it can lead to disinhibition, euphoria, feeling of happy, feels happy, slurred speech, ataxia, disorientation, drowsiness, and the most characteristic features is that the patient will have perioral or perinasal rash. Okay, we call that glue sniffer's rash, that's around nose and mouth, so it will be a hint in the question. Okay, this is also a very important point. And clinical course is rapid onset of these effects and rapid resolution. So as soon as the person takes the inhalants, then he feels these all symptoms rapidly, as well as the symptoms wins up rapidly too. So yes, because the effect is for a brief amount of time, so the people try to be a repeated user of this. Okay, and the withdrawal symptoms can lead to irritability, dysphoria, sleep disturbance, headache, and withdrawal is usually mild, but very rare serious events like arrhythmia and sudden death can occur in case of the patients, people who have been taking inhalant for quite a long amount of time, and if he or she suddenly stops taking this. So in this video we basically talked about what are the different criteria, and total of 11 criteria for saying the person has substance use disorder. And then we talked about alcohol, benzodiazepines, barbiturates, inhalants, okay, and opiates, of course. So we have to remember universal screening for substance use in primary care, emergency and psychiatric setting improves early identification and intervention outcomes. This is one of the key clinical pearls we have to know. Again, we talked about this AST-ALT ratio 2:1 suggests chronic alcohol use, and also urine drug screens that we often hear that the drug test is done by urine drug screening. That has some limitations. So there is always chances of cross reactivity, and as well as we have to be specific with the detection window. So the test will be positive only after within certain period of the time of the last consumption of the substances. And also another thing we have to remember is that most of the people, the substance abusers, they often take polysubstance. Okay, and so most overdose deaths involve multiple substances, and so we must always consider co-intoxication in real life scenarios. And yes, so sometimes the person will be taking benzodiazepines and alcohol, opioids and alcohol. So most of the times, let's say in the real life scenario, are always the chances of polysubstance use. And so to reduce the chances of death because of the substance use, we can always ask for, let's say, process for, let's say, naloxone distribution programs, serious access programs, and medication assisted treatment to save the lives of the person taking substances. And yes, that's it for today's video. This is the last slide, you can watch yourself. So this is it for today's video, and in the next video we'll be talking about other substances, most likely stimulants, and what are the different stimulants, what are their clinical features, what are the withdrawal features, and how do we manage them. And maybe in the third video I'll also talk about another group of substances, and that is hallucinogens, and then we'll wrap up the things. Okay, hope you like the video, and now after watching this video you can always look into your books. And yes, even if you don't look into the books, I think most of the things will be covered for your examinations, so be prepared for the examinations. Best of luck, and yes, we'll see you in the next video, and please don't forget to like, share and subscribe. Okay, bye bye.